This is Dr. Doherty. This is our fifth update on COVID-19, fifth comprehensive update. Dr. Rodrigue will be talking in a few minutes. I wanted to make a few comments. As everyone now knows, this has been a very important intervention in slowing down the outbreak and mitigating risk for healthcare worker to healthcare worker spread, mitigating risk from healthcare worker to patient spread. I'm going to take the mask off right now, however, since there's only Dr. Rodrigue and me in this large auditorium. I wanted to mention a couple of things. First, in retrospect, it looks like we peaked in central Kentucky about 2 weeks ago, or maybe a little bit more. We didn't recognize it at the time. We were able to mitigate the nursing home risk through active intervention with the medical directors of the nursing homes. I think some of the other places in the state are still having issues, mostly with nursing home patients, but that should slow down now with everyone being masked and no visitation. We know that we've been through a major sprint at this point. Now I think it turns into a marathon with intermittent sprints. We think that some of the major issues are going to be prisons and trying to open up the economy again. I think that factories, should be able to safely open up with face masks and potentially face shields. It's going to be a bigger issue to open up restaurants and open up bars. And then finally, opening up schools is going to be a huge, difficult issue. One of the things that we're actively working on right now is how to open up elective surgery. And we've had multiple meetings on that just the last few days. We think that we're going to try to ramp up opening elective surgery here on the 6th. It's a lot more difficult to open up elective surgery than it was to shut down. We are planning on getting PCR testing on all patients undergoing elective surgery within 24 to 48 hours. And so we've figured out a way to do that. We have to figure out a way to use the parking lot as a waiting room. That's not as easy as it sounds like, since our parking structures get very poor cell phone service. And there's just a lot of details that we have to go through to figure out the PPE and the testing and risk stratification. So that's something we're working on actively, and we'll be talking about again over the next couple of weeks. Dr. Rodrigue is going to give a detailed talk now, somewhat focusing on outpatient transitions and also on the complicated area of antibody testing. That's, well, as you'll see, it's very complicated. Thank you, and here's Dan.
Okay, switch it over. You gotta show me the screen. Thank you, Mark. Let's get this show on the road. I apologize in advance if I have too many slides. It's just kind of the way it goes. Here's where we started. This is the very first talk. Panic. First case in Kentucky around March 6th. Stores were empty. We were really struggling as a group of people, not knowing what was going on, how it was going to turn out, were any of us going to be infected, and still a debt of thanks to all of the people that have participated in this, all the nurses, the RTs, the OTs, the environmental people working, everybody working together, the community working together up and down the state to try to mitigate what was going to happen. And remember, when we started this, there was a lot of fear and panic, and we tried to use lessons from previous outbreaks and previous illnesses that we might have experienced, whether it was HIV or some, H1N1 swine flu epidemic, but we didn't know what was going to happen with this. So we started there. We're more in this place. It's not all roses, it's not all rainbows, but we are in better shape, certainly, than we were 2 months ago in the state of Kentucky. We have created processes, we've buffed up our PPE, we've improved in terms of our ability to take care of patients had a little more understanding about the illness, and it places us today in a better position than we were. Today's objectives, I can't go through everything. Remember that all these slides are on a Baptist website, so you can go through them at your own pace. The talk itself is taped, also can go at your own pace. So some of the slides I will breeze over, others I'll spend a little more time. Currently, we have a global epidemic of over 2.9 million cases and 196,000 deaths. The numbers that you'll see will always change, depends on where you go. If you go to Johns Hopkins website, it might be different than the WHO. Part of that is depending upon how it gets counted and updated. The case fatality rate has varied, but overall it's 2%, but it may decrease over time depending upon us being able to test more people and find a different spectrum of disease. The risk factors have remained the same. They tend to be those age over 60 years and those with comorbidities. There are other factors involved in terms of outcomes and case fatality that are still under investigation, such as race. African Americans in the country may suffer a worse outcome, and males may suffer a worse outcome in spectrum disease, something to still be figured out. If you look at the map, it began here in China and has spread now to the United States after a horrendous epidemic, which is still ongoing in Europe. And over time, it's spreading to South America. And this area, Africa, is still a very susceptible area to developing worse disease. Transmission routes are still droplet and contact, the most important, less of an issue, aerosol, although you will find some studies discussing this. It's found in numerous specimens, and as we gather more information, we can still try to put all this stuff together. Remember, there are unbelievable amounts of data out there, articles, probably 6,000 to 7,000 articles. A lot of them are not peer-reviewed and finally published in journals, so it's trying to collate all that information. But nasopharyngeal, nasal, oropharyngeal, saliva is trying to be validated, sputum, are the most common sources, and we tend to think it also depends on the time that you obtain the specimen, whether it's in the beginning of the illness, toward the end of the illness, the yield of those different specimens will be different. It is found on surfaces. The degree of importance of that is still to be determined, but we talk about door handles, cell phones. You can aerosolize this if you have a machine aerosolizing it, and we know with certain procedures you can aerosolize the virus, and that's important in terms of PPE. Asymptomatic and pre-symptomatic transmission have received a lot more publicity. You have to take some of this with a grain of salt, there's a lot of paranoia about asymptomatic transmission, but a significant percentage of people in one point in time might have been tested and asymptomatic, but over time develop symptoms. So they're not truly asymptomatic in terms of their entire course. That's really important to pay attention to, because a lot of times the news story on a clip will just focus on this is asymptomatic, people are walking around and spreading it to you. That's probably not true. The majority are not going to be asymptomatic, although you can look at a study that China publishes that says 78% of their people that they're testing, which is an incredibly high percentage, are asymptomatic. But there's no follow-ups. So it's hard to say in one point in time that those patients don't develop the symptoms. We know from the cruise ships, we know from the nursing homes that there are asymptomatic transmission. We know that there is some asymptomatic transmission within families. We know clusters that have been looked at, but the big picture is a significant portion will develop symptoms later on. Talking about generating droplets and how did we get to a mask for the entire population, not beyond healthcare workers. You can generate droplets with speech. Here's a study showing if you say the phrase, stay healthy, with and without covering. When you say the TH and stay healthy, you actually generate a fairly large amount of droplets. When you wear a mask, a cloth mask here, you actually decrease the amount of droplets generated. Viral dynamics have been important. This is a new virus. It shows us that at the beginning, whether you're having many symptoms or not, your viral load is quite high. And so putting those things together shows us that this virus is fairly contagious, and especially at the early stage of disease. And that leads us to some of our practices in terms of mitigation. If you look at this evaluation of 9 patients in Germany, this is also some comfort. This is how we start to develop some of our ways of trying to decrease transmission. So pay attention to this graph here. This is percent of isolated virus by culture, that by about day 8 in patients, the viral culture is difficult to culture the virus from patients. And if you look at their viral load, when they have a high viral load, this is log, high viral load, the higher the viral load, the easier it is to culture the virus. That makes some sense, but remember, this is completely a new virus. So we're trying to get the dynamics of this. So putting this two together, you can say, if you have been sick for a week and then have been asymptomatic for a long time, even if you isolate PCR RNA, maybe that's not infectious virus. And that's what people have to try to start to understand. Your virus, probably you're not going to be able to isolate, but you actually may detect pieces of that RNA by a PCR test, which is very sensitive. So it's hard to put all these pieces together, but this is where we're at right now, putting it together. This data would suggest that for most patients, after a week or so of being sick, your viral load decreases, even if I can isolate by a PCR your evidence of having RNA. Is the virus seasonal? This is something that's topical. People are talking about it. It's going to disappear in the summer and then come back in the winter. That's still unknown. This is on the left-hand side, you have a graph showing potentially if we had a seasonal virus, this is what we might expect with COVID. Right now, we're in the middle of an outbreak, so you have a large curve of it. But over time, and this is broken down by types of climate, whether you're in the northern hemisphere, the southern hemisphere, temperate climates, tropical climates, what you would expect. And that one prediction is that potentially in 10 years, you would have increases in those cases. But we have a large peak right now, which maybe returns to a higher peak in 10 years. That's if it's seasonal. We know that respiratory viruses are affected by the environment, whether it's dry air or humidity, the length of UV radiation, the daylight hours, human behavior in terms of being in the winter and clustered in indoor time, less ventilation inside versus being outside. And even host immunity has been discussed in terms of your vitamin D levels and the level of immunity. Potentially with longer sunlight, you have higher levels of vitamin D. All that stuff is being discussed. Super spreading events are important. And looking forward, we know we have examples of if you relax some of these guidelines, potentially you could have a flare and a surge. We know that when some of those guidelines were relaxed in other countries, that they had a surge. Singapore was the darling with 100 cases, and it was all over the news. And then within a month, they had 1,000 cases, and they had to increase their restrictions. This is going to be important going forward, especially when we're talking about schools, sporting events, where we're going to congregate people and potentially really magnify one sick person in a crowd of 100,000 watching a UK football game. Homeless shelters and nursing homes have received increasing attention along with prisons. They are magnifiers of this outbreak. Within a single homeless shelter in Boston, cluster testing found that 36% of them were positive, most having fairly minimal symptoms. There are 3 million people who are homeless annually, 500,000 sleeping in a homeless shelter each night. So all these things get magnified when you have an epidemic with a virus that's this contagious. Nursing home settings remain important in Kentucky, magnifying the outbreak. And on the 23rd of April, at that time, we had 251 staff working in nursing homes, 86 resident deaths in Kentucky, 1 staff death from a nursing home, and 59 facilities in Kentucky with a case. Here's another evaluation of homeless shelters. You can see that the percentage when they go into, these are homeless shelters from Seattle, Boston, San Francisco, significant percentage of the residents are positive. So even if you have great control in your community, but don't pay attention to high-risk areas, whether it's your prisons, your nursing homes, you're going to have that become your problem. Some news talking about disinfectants and outbreaks that occur related to this outbreak. So there's been an outbreak of poisonings, increase in cleaning and disinfectant exposures. It didn't begin with a Trump mention of using Lysol. It really began with the whole outbreak itself. People were scared. The use of disinfectants skyrocketed. You obviously couldn't find any of these in the stores. And then when you look at poison control reports, they started to increase as we had an increase in the COVID cases. So looking at cleaners and disinfectants, that increased over the outbreak time. Pandemics are colliding. So not only do we have COVID as a pandemic, but in other areas of the world and in even our own country, we have pandemics colliding. For example, in Africa, with the arrival of SARS-CoV, it's been difficult to control HIV and TB. People are not going to clinics to get their medications. You have an increase in tuberculosis, pneumocystis, cryptococcus. You're basically not controlling HIV, which is controllable with medications. But when you remove that because of the fear of COVID, all of a sudden you're spiking other diseases. In the United States, we've had a chronic outbreak of all these chronic diseases: obesity 40%, hypertension 28%, cardiac disease 11%, diabetes 10%. That is intersected with this COVID outbreak. Important because a lot of outpatient doctors are listening to this, and primary care. What we do in the primary care setting really coincides with how we're going to control outcome with this disease. If we don't have well-controlled diabetics, well-controlled hypertensives, et cetera, those patients do poorly with this illness. So we need to pay attention to everything at the same time. A lot of times our focus is going to be on the panic over the COVID, but we've got to take care of our chronic illnesses that are still an issue. Diabetes in particular is a chronic inflammatory disease. And in previous outbreaks with SARS and MERS, it was found to be a significant risk factor for severity and death. Healthcare workers, finally we have some data on healthcare workers that was recently described in the MMWR. Over 9,000 US healthcare workers infected with COVID, 3% of the cases in the United States. That number, however, is artificially low because not all states are collecting healthcare worker data. When you look at states that are collecting the data, at least 11% are healthcare workers. The median age is 42, 73% male, 10% hospitalized, and age and comorbidity still relate to importance in terms of severity in their outcome. We have a national workforce of about 18 million healthcare workers. Age is an important issue in terms of outcome. Here's some age breakdown with the US health workforce in terms of healthcare workers. When you just look at nurses and doctors, you can see that we still have a significant amount of workers that are in the higher risk categories, which I myself are in there. I won't tell you which category, but it's not good. In the United States, we have over 900,000 cases at this time, 53,000 deaths. All states are involved. The first US case was initially thought to be in Seattle, but upon further review, looking at an autopsy case in Santa Clara, it's now identified as likely the first case of death related to COVID from the beginning of February. This was a case that died at home and was eventually figured out by the coroner to have COVID. Samples were sent to the CDC and were positive. At that time, so this is February 6th, there were only about 10 cases in the United States that were documented. Incredible. So we're talking about from 10 cases to where we are now with about 1 million. Community transmission, therefore, was probably going on before we knew it, which is part of what the story of this outbreak is. New York, New Jersey, California, Michigan, those are still hotbeds. Massachusetts, Louisiana. Remember that the outbreak is also not simultaneous. It just didn't explode in these states altogether. It kind of picked its way across the country. If you look at the respiratory specimens now testing positive, about 18% of those sent to public health labs are positive, 10% at clinical labs, about 20% at commercial labs. And there's a cumulative test, this is cumulative testing in the US of over 3 million. But that's cumulative from the beginning of this outbreak. Hospitalization rates continue to go up, 29 per 100,000, but look at what happens the older you are. So it goes up to 95 per 100,000 if you're 65 or over. This is some of this data is available on cdc.gov. They have a COVID net surveillance system in 99 counties in 14 states. Here's a summary of the number of tests being done. This looks like it's more, but it's still far short of where we need to be. The outbreak curve is pretty self-explanatory. Here's your earliest cases reported around here in Seattle, and that patient that came from Wuhan to where we are now. The outbreak map's pretty self-explanatory. Kentucky doing fairly well in terms of the color scheme. It's lighter than some other areas of the country. Hospitalization rates still hold to be about the same. You get hospitalized. A lot of stories right now in the news about mitigation efforts, the outcome in terms of the economic cost. Was it worth it? And then what they're using specifically a lot of times is death rate. It's not about the death rate per se. It's about resource use. And if you look at this graph, it shows you that it doesn't matter, even if you were young, you used resources. Even if you were in this age group, 20 to 44, a significant percentage of those patients still get hospitalized. They don't use the ICU as much. And clearly, as you get older, your resource use gets up and your ICU use gets up, but you use the resource. Map of Kentucky has not changed much. We still have some concentrations in Fayette County, Jefferson County. A lot of this area right here is involved with nursing home outbreaks. What about, how do we compare to the gold standard, which is New York? If we try to get similar rates, this is a rate per 100,000 people in your state, we come out pretty well. I mean, Kentucky is down here, New York is up here. I don't know how well the rest of these lines project, but basically each line is a state. So we're in pretty good shape. If you look at the epidemic curve, as Dr. Doherty mentioned, this is a predicted epidemic curve. As of the 27th, we're probably past our peak as a state. And important to note, this curve was created to show you total available beds, ICU beds needed, ventilators needed. We didn't get the surge that overwhelmed our hospitals as it did in some other areas of the country. Fantastic. I think that's part of the mitigation that we did in terms of our social distancing, use of masks, enhancing our infection control practices. Awesome job. That's a great thing. Now people can complain and say, well, no, it was at a cost that was too much. Well, it's easy in hindsight to try to come up with some incredibly complicated calculus of doing. We did a great job so far. Can it change? Yeah, of course it can change, but we did a great job. Healthcare workers did a great job. Administrators, people did the best they could. This has been going on, people have been working on this 24/7. And the benefit is the cases are down. We did not get overwhelmed, and we have strengthened our infrastructures and processes in hospital. This is a contagious virus. It's not as contagious as measles, but it's contagious. Let's get into some serology. Here's a brief anatomy. You have these spike proteins that attach to an ACE2 receptor. And you have other parts of the virus where people are going to look at creating serologic tests. So where do we stand? What's a serologic test? It's a blood-based test to identify whether people have been exposed versus a PCR test, which indicates the presence of the viral material, the actual RNA during infection. So there are lots of different assays, lots of different ways to do serology. Enzyme-linked, rapid tests, and the state of the art is still really complicated. Tests can have different sensitivity and specificity depending upon their technique. depending upon what antigens are being targeted. And there are generalities being used, but specific parts of the virus that are being targeted are slightly different between all the assays. Every country involved in this outbreak has developed their own assays. Universities are developing their own assays. Usually they're based on targeting the spike protein or the nucleocapsid protein. We have 4 tests now that are lateral flow assays approved for testing. They're rapid testing. And the insert here shows you what it typically looks like, which is like a pregnancy test these are rapid tests where you put a sample, you wait a short amount of time, and you get a line. So 4 of those are currently approved. But what does the approval mean? Remember, these are approved under the emergency use authorization. And if you look closely at the level of evidence needed to approve, it's still relatively small. The samples that are used and compared, looking for cross-reactivity with other coronaviruses, with other respiratory viruses, sample sizes are fairly small. We're talking on the order of 100 to 200. We're not talking about thousands. And then they are not validated in large population studies. So what do these tests mean? We still are in the process of trying to figure that out. They are not gospel. And I think that we'll learn more over time. The FDA and CMS has taken the approach that trying to get stuff to market to try to get a handle on what's going on. But at the same time, there has been a little bit of a Wild West show going on in terms of all the tests reported. There are thousands of different articles, different techniques, which makes the literature a little bit confusing. Nevertheless, people are looking and using this for starting to get a snapshot of what's going on in communities. That's where we start to use them. Seroprevalence. If you look at Santa Clara County, they recruited through Facebook ads 3,000 subjects with a test that had an 80% sensitivity and a specificity of 99%, and estimated that maybe about 2 to 4% of their people in their community were positive or had been exposed to COVID. LA County used the same test and estimated about a 4% seroprevalence in their study of 800. Now, a lot of this depends on who are you going to gather in terms of the validity of these studies. Do the people that you test represent your population, or were they selected? For example, if I choose people from Facebook, does that mean, one, they have an operating computer with an internet service, maybe they have a different socioeconomic status? It starts to give you twists and turns about how some of the data are reported. But it's a glimpse that there is a prevalence within your community. And then, not surprisingly, New York has done some of their own sero surveys and found that in New York City, over 20% of residents show some kind of a signal that they were at least exposed to the virus. But it's not equal. If you look at other parts outside of New York City, it really goes down. So if you look at the entire state, it's only 3%. I would hazard to say in Kentucky, it's probably less than 4%. We haven't had a lot of cases. If you look at the percentage of specimens that are positive at UK, it's about 4%. If you look at our overall number of cases, it's relatively low. We probably don't have a huge seroprevalence. So what does that mean? Social mitigation, masks, everything else did work in terms of spreading it in the community. Looking at, and here's University of California, San Francisco, and Mass General went and looked at they looked at 10 lateral flow assays and 2 ELISAs to try to figure out how well did they perform. They didn't like any of them. They only liked 2 out of the entire group in terms of sensitivity, specificity. One of the difficulties with these types of tests, there is no gold standard. So really, a lot of these papers are written on the basis of comparing one to the other, and still small numbers of people. So you're evaluating these assays. You're using controls from 130 specimens from 80 symptomatic COVID patients, then previous samples from other respiratory virus patients, and trying to figure out whether or not they're good tests or not. The bottom line is they weren't very happy with the performance of the test. So I think the message from a lot of the serology is it's still a work in progress. What are we trying to get to when we develop antibodies to begin with? We're trying to show evidence that we are immune, that we are going to be protected. We don't have that data. We have the beginnings and some insights into that data, but we do not have one test that can tell us that right now. But we do have some snippets of information that give us insight into what we can expect. So if you look at this Finnish study, you do develop some neutralizing antibodies. Remember, a neutralizing antibody is able to show that using your serum, if you got exposed and you put it into a cell culture medium, that you protect those cells from having some kind of cytopathic effect. And you do that, and you can titer your serum to say, well, actually, you have a strong protection in this cell culture experiment. But it doesn't tell you whether it's because we don't have those models developed yet. If I look at an animal model, whether it's a mouse model or a macaque model or some other model to show that truly your serum is going to be protected, we don't have that. We have surrogates. So this Finnish study shows, yes, you do have some protection. It wasn't instantaneous. It developed, probably after the first week, and not everybody developed it at the same time. Same thing when you looked at this study, 175 patients with COVID, and interestingly enough, and this is not, how this will play out, we don't know, but there was an age-related difference in the level of protection that you would get over time. So the older you were, which is on this level, 60 to 85, your titers for neutralizing antibodies were higher than if you were younger. And in fact, in this study, and then remember, this is 175, all were positive by PCR. If you were younger, some of those patients didn't even develop a signal for neutralizing antibody. I don't know what that means, and we'll have to figure that out going forward. Another study looking at 117 samples from 70 COVID positive patients and their convalescent serum. Similar story, and these are done in different places and not always done exactly the same way, but they still give you a flavor of what to expect with immunity. Age still important. The older you are compared to the younger you are, you had more likely to show a neutralizing antibody. If you had severe disease, you're more likely to show a neutralizing antibody. And time made a difference. So the time period that they talk about is probably after 21 days in this study. So it takes you weeks to develop some of that immunity, which makes some sense. Now, the other thing that we briefly touched on was that the other testing that we still talk about is PCR. Not all PCRs, however, are created equal, and they all are different, slightly different in terms of their techniques. They might target one, for example, the CDC assay targets more targets for trying to amplify that RNA versus some of the other assays. They're not all done the same way. And these were all eventually approved under the EUA criteria, the emergency use authorization, because of this incredible pandemic going on at the same time. But the validation in terms of thousands of patients, that's not really been published. So they're based on smaller assays, but you can see they're all not exactly the same. Some of them have different limits of detection, and that's basically in the lab. That's their performance in the lab. When you talk about their performance in the field, using it on clinical samples, really makes a difference. The last big story we talked about was the Abbott ID Now, which it'd be great. It's a quick test. It seems to have great sensitivity in terms of 125 copies per ml. However, there were issues with its performance in the field. And some of that has been improved with the difference with some of the collection techniques being used. For example, not using a viral medium, but actually using a direct swab. But all that had to be worked out. And it led to some confusion about how are we to rely on some of these tests without knowing all their characteristics. The message is, you got to do due diligence to figure some of that stuff out when you employ some of these tests, especially as we go forward using them for screening our patients coming back into the system when we talk about elective surgery. Clinically, things haven't changed that much. We still talk about this as a viral illness with probably two major stages. The first week being relatively mild. The second week, you transition into potentially severe disease if you have the wrong risk categories, and that your viral load decreases toward the end of the second week. Onset to hospital admission is about 4 to 7 days. Here's the first patient out of, well, here's one of the first patients out of Washington, just as an illustrative, as a 2-week disease. He had fever during that first week, which tailed off. He had a cough that lasted weeks, which is not uncommon. Some of our viral respiratory pathogens can give you a cough that persists for weeks. Typical X-ray findings, talking about the ground glass, which hasn't really changed. Some Kentucky patients, here's the first patient I saw came in with a herniated brain, essentially, after a large CVA. And initially I thought, well, you know, he probably had a CVA and had COVID. But actually, in retrospect, COVID probably participated in his developing a CVA. It's an inflammatory disease. Here's another case to illustrate what happens during an epidemic. 19-year-old kid comes in with cough, weight loss, and sweats with low-grade fevers. He was quarantined at home for COVID. Schools were closed. He spent time at home. He continued to have cough, fever, and weight loss. Now, if I told you a patient before COVID had cough, fever, weight loss, and night sweats, with this X-ray, you'd think he might have tuberculosis. And what did he have? He had tuberculosis. He didn't have COVID. But because of COVID, it actually it probably interfered with the diagnosis of TB. So we got to be sure we think with a broader vision. Just like my stroke patient came in, you can come in with a different presentation. It might be a myocardial infarction and COVID. It might be a stroke and COVID. This patient actually had tuberculosis, but if we're just COVID focused, we've missed the TB aspect of it. This is more typical 43-year-old male coming in, morbidly obese, cardiomyopathy with an EF of 10%, who was admitted with a viral syndrome and rapidly progressed, developed respiratory failure, and he received all these therapies: hydroxychloroquine, tocilizumab, convalescent plasma, and he eventually got extubated. This was his presentation in terms of his day 1 chest X-ray, which really just shows you, the cardiomyopathy and fluffy infiltrates with probably pulmonary edema. Many of our patients are not getting CAT scans at this point when they have COVID because it just increases the risk of exposure to other parts of the hospital. So to summarize, the symptoms aren't specific, the labs aren't diagnostic. Maybe they do have some lymphopenia. There are some labs associated with increased risk, which I list there. You can shed for a while. For most patients, if you don't have risk factors, it's a 2-week disease. For others, it's a 6 to 8-week disease, depending upon how sick you are. I try to summarize this. It's not to scale, but this is trying to put together some of those concepts. The beginning of the illness really is, you might have an asymptomatic or pre-symptomatic phase of days. Remember that the incubation period is usually 5 days. Then you have a mild illness maybe for the first week or so. During that time, you have a high viral load, which eventually goes down. And you start to develop your immune responses after potentially the first week, where IgM goes up and then goes down, and then IgG goes up and it stays up for a lot longer. This is the period where you basically can transition. If you're in a high risk group, you have a severe, whatever your host factor is, maybe you have a super high viral load, you can transition into this severe disease. So the initial part of it is really a viral illness. But the second severe part is really an immune illness to a certain degree, where you have a hyperimmune response, cytokine syndrome, ARDS, and really our therapies are kind of focused thinking now about that paradigm. A couple of unusual coverages of unusual clinical symptoms. So neurologic presentations. This isn't uncommon. This is not uncommon. SARS, and remember that there's about a 70% homology between SARS and SARS-CoV-2, had information, if you look at autopsy series, that SARS did involve the brain. In 18 out of 18 autopsy study, in one study, they could demonstrate SARS within the brain itself. So you might have a mechanism that begins through the olfactory bulb. Remember that anosmia, in terms of losing taste and smell, can go away. There is an ACE2 receptor in that area, and there's also ACE2 receptors in the neurons in the glia. So it's not unusual to think that actually it could involve the neurologic syndrome. If you look at the reports, it's a little more difficult to gather some of that information, but myelitis, hypoventilation, Neurologic symptoms in anywhere from 25 to 40% of patients. And you can even get Guillain-Barré, a case series of 5 patients with Guillain-Barré. Another report looking at COVID patients had 5% of them with CVAs, one with a venous sinus thrombosis, one with an intracranial hemorrhage. Here's a series of 64 patients in the ICU in France. Most of the EEGs were okay, but a significant percentage had some neurologic sign, whether it was agitation or encephalopathy, but it was important. Second, another unusual manifestation is the eye. So previously reported with conjunctivitis, retinal vasculitis, retinal degeneration. Here's a series looking at a patient that had a conjunctivitis which decreased over time. That's up to, this is day 19, this is day 13. And actually we were able to isolate the virus from the eye itself over time. But then again, by the time you got to this stage, it was basically undetectable in terms of PCR. Here's a patient that presented to the outpatient setting with a watery eye and ended up having a keratoconjunctivitis. This patient went to the clinic 3 times before being subsequently diagnosed with COVID. If you look at the studies from China in terms of their 10,099 patient study reported in New England Journal, 0.8% of them had some type of conjunctival appearance. Here's something you might also see in the outpatient setting, and that's dermatologic manifestations. In a series of 88 patients, you had cutaneous manifestations, some at the onset, which included rashes, urticaria, chicken pox-like vesicles, a trunk usually being the primary site. In one study, petechiae were mistaken for dengue. That was in Thailand. You have levedo reticularis, mobiliform rashes. Nonspecific rashes have been reported frequently. You have drug rashes to the medications we're giving them, such as hydroxychloroquine. You have the N95 injuries that nurses and doctors report. Here's the varicella-like exanthem reported in a series of 22 patients out of Italy. It looks a lot like chickenpox. And here's the COVID toes that have been reported. This also out of Italy, acroischemia in COVID-19. Some other manifestations in the toes as well. Some of the stuff you might see in the outpatient setting. Severe disease occurs in 10 to 14% of patients that can occur in any age group. So initially, there's been different reports from different series. And one of the things you'll gather from this is that there are reports from China, there are reports from South Korea, there are reports from Singapore. Every country kind of reports what they're doing with their patients, and they usually have similar article names. Severe cases in Italy, severe cases in wherever it may be, and they're all slightly different. Within our own country, Seattle reported the first group of patients that were severely ill going to the ICU, and it was fairly horrendous. I mean, most had a 50% mortality rate of those people that required a ventilator, which coincided with what was reported previously. Length of stay was weeks on end. But interestingly, I think what we'll find over time, and this is just one of the first articles that kind of gives us a hint, and within our own patients, we could also say there's a hint that there may be a learning curve to how patients do. So Seattle reports 50% mortality, but Emory, which had a larger series of patients, reported a 30% mortality on those that went to the ventilator. So potentially the way we're looking at patients, the way we're intervening is improving their outcome over time. That's not uncommon. Remember, this is still a new illness with new manifestations. So what we recommended 2 months ago as being modified as time goes on, as we gain more experience. So again, this is the framework that we're looking at going into our patients and looking at clinical monitoring and therapeutics. Monitoring wise, we monitor their O2 sats, usual vitals, respiratory rate, especially if they start to take off and have a respiratory rate of over 20, 22, we start worrying that they are going into a more severe phase of disease. We're measuring CBC, complete metabolic panel, CPK, tests that we think might give us insight into being a biomarker for severity of illness. IL-6 is measured, but it's not back in real time in our institutions here. Radiographic studies, we don't necessarily repeat them every day unless clinically needed. We're not getting CT scans on all these patients. There are many articles written about predictive models. Can you use something like a SOFA score or an Apache score to predict who gets sick? Here's a call scoring system based on comorbidities, age, lymphocyte count, LDH. There are other markers, respiratory rate, lymphopenia, and every article has a slightly different number that they report. And so when you look at institutions, like say, what does Hopkins use? What does Yale use? What does Mass General use? What's UW use? They're slightly different. There's no uniform. Eventually, I imagine there will be. Somebody will put some weights to it and say, and then it ends up in up to date or something, and then that's what we'll focus on. But for right now, they're slightly different, and you have to get a certain comfort level with what's going on with these biomarkers. New York is probably the most recent report of their 4,000 patients that they thought their O2 sats on admission, the D-dimers, ferritin, and CRP, that those were predictive of who was really going to do poorly. General guidelines for treatment haven't changed much. We're still trying to shorten length of stay for other patients, considering discharge with telemedicine visits. We try to choose medications and treatments to minimize healthcare worker exposure, and whether it's nurses or doctors, and then continuing to deliver care to those without COVID so that we don't drop the ball on our other patients. Oxygen is probably the most supportive thing that we do. It will be required in the majority, up to the majority of our patients that are admitted to hospital. And antibiotic use is common because it's difficult to distinguish who has an infection and who doesn't. You could potentially use a procalcitonin level being normal, but it's difficult to distinguish. So especially the sicker you are, the more likely you are to get antibiotics. But if you look at the incidence of secondary infections, it's still relatively low, probably on the order of 5%. Anticoagulation treatment is important. Part of the syndrome of how sick you are is related to some of the pathology of a hypercoagulable state. And so many articles are now being written about looking at paying attention to D-dimers and that anticoagulation state and whether or not they'll do better. One study reported 99 consecutive patients and broke it down into D-dimers. So along this line, you see D-dimers, and you have 28-day mortality. And when the D-dimers start going above 3, there's a statistically significant benefit to anticoagulating those patients. So in looking at heparin versus non-heparin, the non-heparin users with mortality is higher than the heparin users. Excuse me. So we know that significant number of patients, especially the older you get, are going to need the ICU, and that their case fatality goes up. And that we're starting to learn over the past, at least probably the past month, that this is a story that has changed some. So initially, 2 months ago, the story was, oh my gosh, if you have respiratory failure, you need to be on a ventilator ASAP, and that everybody fails. And now there's been a certain subtlety to that message that's been changed. Dr. Gattigononi, I'm sure I'm saying it the wrong way, from Italy, who's prominent in the critical care community, has kind of summarized some of the information that they have obtained from Italy and from other parts of the outbreak in a recent JAMA article, talking about there's probably phases of respiratory failure that are more subtle. Prior to doing this 2 months ago, there was really an emphasis to not use any non-invasive ventilation, but now there's a little bit of a subtlety to this, meaning in the very beginning, which has been clinically realized or reported on, patients can sit there talking to you without much respiratory distress, but have O2 sats that are 60. And at that phase, they're probably still having inflammation. They have a lot of EQ mismatch, but their lung is relatively compliant. Their work of breathing is minimal. So they don't really suffer that air hunger as much. They might have an increased respiratory rate, but it's not overwhelming. They could be talking to you and doing their activities. But as time progresses, they can transition into the more typical ARDS, where your lung becomes stiffer and stiffer. You have some of that fibrosis and inflammation setting in, and then those patients tend to do fairly poor. And you can transition from one to the other relatively quickly. So you have to pay attention to those vital signs and where that patient's at, whether they have potentially other biomarkers that suggest that they might be more likely to transition. That data is still being looked at. But you're starting, this is kind of describes as you continue to go on, you have more endothelial damage, probably more thrombogenesis, where you're having microthrombosis in the lung, and then you're developing more of a stiff lung and ARDS. And he summarizes that here, talking about before intubating, you're looking at just supplementing the oxygen, potentially using non-invasive ventilation if they're in that low compliance state, all the way up to, and proning, awake proning, all the way up to the intubation phase, where you're in more of a difficulty, but you're trying to minimize ventilator-induced lung injury with whatever you're doing in terms of the ventilator. We have to treat our airways with caution, because remember that airway and intubation is how we can also potentially aerosolize and infect ourselves. So we establish protocols, tracheostomy protocols. Typically, for some of the papers, trying to do it, if you can, in a negative pressure in the ICU rather than taking them into the operating theater. But that's something that every institution has to evaluate. But importantly, if you're intubating, you have to pay attention to PPE. So here's experienced ED docs using a video laryngoscope and using a model that generates, using GlowGerm, generates potential coughing during the intubation procedure, and what potentially can happen to those workers. And that is, you've got to pay attention while you're protected using that face shield and the N95. You can still, around other areas, and here's showing exactly where those areas might be, get some contamination and paying attention. Now, what's the significance of this is not really discussed as much. Typically, you're not going to have the virus absorbed through your neck to make you sick. But if you don't pay attention, you're touching your neck and your face, and you start to rub your eyes or put your fingers in your mouth or something while you're eating, that's another way to get sick. Let's switch to therapy. Way too busy slide, but this, again, these slides are available for you to look at. This is just one schematic looking at the virus, its entry using an ACE2 inhibitor, entering into the cell, where are the various areas that we can look at treatment. Looking at the different, for example, remdesivir in this area, cytokine storm, and using tocilizumab or some of the other IL-6 blockers. But this is the reality. Oh my gosh, you look at this slide and you go, what the heck? There are so many trials going on, and there are hundreds of trials going on. And this is a schematic as of about a week ago of how they're all related. So they're this versus this versus this, combination of this versus this. I mean, it's unbelievable. And the numbers themselves are some of the trials involved and stuff. So there's 51 trials involving chloroquine. There's 8 trials involving remdesivir. There are many, many trials out there, and we get splits and splats of the results of these trials, oftentimes on Twitter before it's actually in a journal. So makes it difficult to figure out what's the standard of care. Initially on, we said steroids no, but over time, steroids may have a benefit. We know from past SARS outbreaks, giving steroids, especially in some patient populations, increased viral shedding, especially if it's used early. And remember the paradigm that initially in your illness, it's probably all about the virus, but as time goes on, it becomes about the immune system. So it may have a role in ARDS and shock and in the cytokine storm. Remember, there's no FDA-approved treatment, and the National Institute of Health, the NIH, and the IDSA have now put out guidelines, and it's still a work in progress, but basically the The gist of both those guidelines are that there is no FDA approved treatment and that you need to consider treatment in the setting of a randomized clinical trial. That being said, if you look at each institutions, because there's a lot of institutions that are still putting out guidelines, and I'm talking about from Mass General, UW, Michigan, Penn, Pittsburgh, everybody has their set of guidelines. A lot of them say randomized clinical trial, but if you're going to use it, consider this. So there's still some wiggle room in terms of using it, but as more data comes out, well, it'll be more solidified. I've kind of highlighted some of the drugs that are still being thought of more favorably, but as time goes on, that may change. So remdesivir, convalescent plasma, tocilizumab for the cytokine storm, steroids and ARDS. And then these have become in smaller print in terms of hydroxychloroquine as we get more data. Vaccines are still under development and probably still a year and a half away. Here's the latest algorithm for COVID from UW, which basically it's no longer recommended. These things have changed. It's no longer recommended as a routine, but in their description of the guidelines, if you discuss it with infectious disease and the patient's not in a eligible for a clinical trial, they may actually still get it. A lot of the treatment data for lopinavir, ritonavir has kind of shied us away from using that medication. Hydroxychloroquine had a lot of press in the beginning, but as time has gone on, the trials haven't been so as favorable. It doesn't seem to be as much of a viral load effect, although some studies have stated that patients felt better, but there are still very small, relatively small studies. One that has gotten a lot more publicity recently is this Brazilian study that was stopped for high-dose hydroxychloroquine in terms of cardiac side effects, but realized that every single patient in the high-dose and the low-dose arm was receiving azithromycin, which pretty much nobody is using because of the cardiotoxicity outweighing the benefit. That QT prolongation was an issue with that study. Ivermectin was published as an in vitro, but no in vivo data. Even metronidazole has been mentioned. So remdesivir has been developed initially for Ebola and inhibits an RNA polymerase. We have a little bit of data in terms of a compassionate use that was published in the New England Journal, where they seem to show some potential benefit that people had improvement, but these are still relatively small studies. But then we have this, which is this one I'm saying in terms of the level of the state of the art. This was on a website and then it got taken down. So on a website, this was another trial saying of 237 patients that it did not have a benefit at 28 days for patients with severe disease, but that is now no longer available. You can't find that study. So it was briefly up there and then it was taken down. It's not on Medrix, which is the pre-publication server. It's not in any of the journals. So it's probably going to be published within the next month, but it's not out there yet. But that was a little bit of a disappointment for people backing remdesivir. Hydroxychloroquine is no longer routinely recommended outside of a clinical trial, but if it was used, you would use it in a lower risk, a lower dose regimen, probably in patients that have some respiratory failure and no other contraindications. Remember that checking a QT would be important and monitoring that would be important because that's the main source of toxicity. If they had pre-existing retinal disease, I wouldn't use it, but any of the other illnesses are not really significant. This is a relatively short course of therapy. Immune modulators have gotten a lot more press, and that is using, remember the second phase if you're developing severe disease and then a cytokine storm. So tocilizumab is one that we have used in the system and has had some benefit, we think, for our own patients, but it's still small numbers. You can demonstrate an effect here, and I don't know if you can see this, but basically you can demonstrate that there is a decrease in potentially CRP, fever, but mortality benefit is still not that clear. You need larger numbers likely to see whether we're going to decrease the use of ventilators, whether we're going to decrease ICU use and decrease mortality. That data is still pending. The other data that are reported are small studies, 15 out of 21 patients in Wuhan improved. But again, the studies themselves are difficult to interpret. a lot of those patients received other therapies. They received steroids. They received Kaletrol, opinavir, ritonavir. They received other therapies. So it makes it difficult to figure out what the effect was of using the tocilizumab. Here's a study, again, here's the level of data. This study just came out yesterday, but it came out in a press release. It's not in a preprint release. It's not, you can't look at the data yet. Now, when we see the data, probably we'll see it in a week or 2 or 3, but big publication is saying in France that there was a benefit, randomizing 129 patients to receiving tocilizumab plus standard of care, which meant, by the way, they got other therapies, hydroxychloroquine or steroids or something else. So standard of care versus non-standard of care with, so tocilizumab seemed to have some kind of a benefit, but the data are not available, which makes it really difficult to push your patients one way or the other. There is some prudence to using randomized clinical trials for some of these therapies, especially if they're harmful to our patients. At the same time, we have to understand that sometimes we can't enroll in a randomized clinical trial if you're in a community hospital and don't have the infrastructure. So we have to use best judgment. What about steroids? So initially we said steroids no, but now we say steroids maybe, especially in patients that have ARDS and cytokine syndrome. A lot of that data is using a surrogate for what critical care has looked at before in terms of ARDS. So they've looked at and come out with a recommendation for ARDS that it may be beneficial. That's based on some of this data. We'll say, right here, by the way, I looked at the meta-analysis. So there's meta-analysis now looking at some of the steroid use from Chinese articles. Very difficult to interpret, hard to figure out. Most of them are not that supportive of using it, but it's hard to figure out. There are so many other factors being involved in those trials that are reported that, and this is also not peer-reviewed literature. The critical care doctors use this type of information. This was the basis of the recommendation from the Society of Critical Care Medicine and the European intensivists saying steroids may have a benefit in ARDS. If you used methylprednisolone, dexamethasone, you had a difference in ventilator-free days, and you had a difference in duration of ventilation. So they're interpreting some of that data and applying it toward COVID. Whether or not that's perfectly good, I don't know. Convalescent plasma, we've gotten some traction in Kentucky. We have used convalescent plasma in a number of patients. Now, many of the systems, whether it's the CHI system or the Baptist system, is enrolled in the Mayo Clinic cooperative to give convalescent plasma to our patients. That's based on small clinical trials, which are 5 patients here and 10 patients here, that show potentially some benefit, and previous outbreaks of SARS, MERS, and swine flu, and even the Spanish flu in 1918, that there was potential benefit. So that's still a work in progress in terms of what might go forward. This may be part of the future on the right-hand side. So while it's difficult to get convalescent plasma, we can create monoclonal antibodies. So if you look at a monoclonal antibody, this is the infection percentage using a monoclonal antibody concentration. As you get up along this line, you can actually show a neutralization of the virus. So people are working on different monoclonals to try to bring that to market as a more consistent way beyond convalescent plasma to treat our patients. So here's a summary of looking at some of the treatment aspects. Initial part of the disease is a viral illness. We may be giving these antivirals early, like we do in flu with remdesivir and potentially plus or minus hydroxychloroquine. As they progress, probably thinking about convalescent plasma, or in this area, potentially using monoclonals. And then as they get to the immune phase, using some kind of immune control, whether it's steroids or tocilizumab. This right there, sarilumab, there is one study out there that didn't show much of a benefit, but that's kind of how we're looking at it. And in terms of the outcome of our patients, seems to have some effect. So how do we discharge the patient? So we've had success and now we're discharging. First of all, isolation is per public health recommendations, whether it's at home or at the nursing home, to get them to another long-term care, whether it's nursing home or rehab, typically requiring 2 negative PCR tests for those high-risk situations. You discharge based on whether that patient's safely able to be discharged. So it depends on if you're discharging them home, you need to make sure that they have the support at home to allow them to recover. So use your usual clinical criteria in terms of the stability and the availability of support at that next level of care. Communication is key in terms of discussing to caregivers, whether it's the people at home or whether it's their primary care physicians. This is an area where we continue to need to improve. Baptist is doing, I think, a great job trying to contact primary care providers. They spend a lot of effort trying to make that a better process. But not all systems are able to do that, but they need to do that. You know, the system of primary care has been a little bit disconnected from the hospital because of the development of the hospitalist service and what primary care docs aren't going into hospitals anymore. So that continuity needs to be reestablished, especially for patients that are getting discharged with this disease. The components of the handoff are listed there. They include telling them basically what happened and what to expect, and what's the level of their organ dysfunction at discharge. And then there are arrangements being made using even new technologies like this current health monitor arrangement, where patient might go home at the Baptist system with a monitoring device which monitors their O2 sats, their blood pressure, respiratory rate, et cetera, and using artificial intelligence may actually notify home health nursing or provider with when they're out of kilter in terms of whatever parameters you set there. Antibody testing is not a routine part of post-hospital care as of today. Now, is it going to be in the future? I don't know. But right now, I would not be doing antibody tests on any of these discharged patients. What are you going to expect when you see that patient as a primary care provider? First of all, you have to understand, you know where they came from in terms of their hospital experience. You know that they're either going to have a mild or more serious illness. And we don't have all the data. I'm talking about years of data or months of data on the sequela of these patients, but we can extrapolate based on previous outbreaks about what to expect. Most people have mild disease, which is thankful. They might not even be in the hospital, and they're not likely to have a long-standing problem. However, if you're more severe, you're going to have some issues. We know that there's myocardial injury up to 20%. You may benefit from a follow-up echocardiogram. You might have pulmonary fibrosis and may benefit from a CT scan at a later date to just see what the extent of disease is. You might have a neurologic injury, DVT sequela, renal failure. All those are potentially outcomes of patients that are more seriously ill in the hospital, and that's something that's handed off to you to manage with the support, whether it's a specialist or your own expertise. This is what you might expect to see if you actually had a piece of their lung, depending upon what stage. It just gives you an idea of what they're going through. And that's in the early stage here. It's really kind of an exudative stage, a little bit of a hyaline membrane, but as you go along, you have more thrombi, and they're pictured here, little thrombi right here. As you continue to go on, you have more and more proliferation of the fibrosis that goes on, which really does affect their exercise ability, their ability to function well, and their recovery is longer. If I was to do another extrapolation, I'd look at SARS patients. And on the right-hand side, here's some long-term sequelae looking at SARS and MERS patients. On the outside, here's a picture of what you might, and it's broken down into, you know, how they feel about themselves, their general health perspective, their limitations, social functioning, et cetera, physical functioning. If you're normal, you're out here. If you're really sick, you're out here. And this is broken down by time. So the SARS patients, for example, before 6 months really had a lot of limitations in terms of this type of graph. But over time, they did expand, but they never quite expanded, certainly to this area right here, which is considered normal. So they may have some longstanding issues with exercise capability, with impaired diffusing capacity if their lungs had a little bit of fibrosis. That's what you need to take into consideration when you're looking at that patient in terms of what surfaces they may need, what to expect going down the line. We're moving forward now. We're still identifying patients, creating a process for evaluating, especially our pre-op patients, for example, the PCR screening of pre-op patients 24 to 48 hours prior to their procedure. We're still isolating, trying to use good infection control measures as we start to open up for protecting our patients, our healthcare workers, depending on the circumstances, using engineering controls, administrative controls. Remember, elective procedures were closed on March 18th, and now we're moving toward opening them in May. And the governor came out yesterday with some of these phases, and there's up to 4 phases. So yesterday came up that non-urgent and non-emergent healthcare services are starting to open up, resuming in the hospital. Non-urgent invasive stuff was excluded. We don't want typical things. We are not returning to business as usual in terms of how we're organizing care. So waiting rooms are kind of out. We have to utilize non-traditional alternatives, whether it's calling ahead, whether it's waiting in a car. Dr. Doherty mentioned some of the difficulties with parking structure. It depends on how your hospital is set up. It's not going to be perfect. And again, we have to modify our practices based on what we have and make it work. We're still going to be maintaining social distance, continue screening healthcare workers and our patients, enhanced hygiene, and patient masks. As we move forward on May 6th, outpatient ambulatory invasive surgery resumes. We still have to have COVID testing, maintain our PPE, and maintain a capacity in the hospital for surge. Again, phase 3 on May 13th. So at least we have dates to look forward to, assuming no surge, because things can go backwards if things get out of control, if cases get out of control, but resuming non-emergent surgery at half your volume and still doing the COVID testing and maintaining PPE. And then lastly, by the end of the month in May, really resuming all the non-emergent and non-urgent elective surgeries and continuing the testing and maintaining a supply of PPE. How do we go forward? We need to have communication between public health and community stakeholders, the healthcare system, schools, nursing homes, prisons. It requires testing, contact tracing. It requires us to be able to detect increases in surveillance within our own organizations, whether it's the hospital or the nursing home. We have to pay attention to what is happening there. That may be the signal that says it's coming back in the community. And it may not be, you may be lulled to sleep over the summer and then have something return with a vengeance in the fall. There are some unusual ways to monitor. One article mentioned monitoring wastewater. To look for RNA signals that you actually have it in the community. We're going to probably have to test in schools. We'll wait for saliva testing to be validated, but school-based clinics, random sampling, point prevalence studies. And I wrote down a couple of numbers here because if you look at some of the studies, whether it is the Rockefeller paper that was published, a lot of this stuff's been published in April. Rockefeller does a white paper. Duke Margolis paper. There's a couple of different papers written down that have numbers associated with it. And I tried to put that into a Kentucky setting. So they're talking about using up to 1 million to 3 million tests per week, the capability, and to have 300,000 workers nationwide to be able to do some of the work that's going to be needed for contact tracing. How does that correlate to Kentucky? I kind of based it on our population. So that means we need to do about 11,400 tests per week, the capability. And remember what we've done 48,000 tests per the whole outbreak. Well, I'm talking about per week. And in terms of the number of people, based on our population, probably need maybe 3,000 extra healthcare workers, whether it's healthcare workers or it's basically public health workers to help with the workload. Whether that'll happen or not, I don't know. So the new normal is to continue to work toward vaccine and therapeutics. Public health measures are still going to be important. They're not going to go away. We don't have an awesome treatment or an awesome vaccine to protect us. Even with Tamiflu and a flu vaccine, we still have yearly flu outbreaks and still people get sick. So it's not going to be a one size fits all and it'll all be good. We're still going to have to maintain vigilance to try to protect the healthcare system, protect our healthcare workers, protect our patients going forward. That means paying attention to the masking and hand hygiene, which may continue it may be a new normal, a cultural normal, whether it's in the elementary schools or the colleges, office settings, work settings. We might need to readjust that aspect. That's low tech. That doesn't require a PCR. And certainly that's probably been the most effective thing. It's not developing a PCR test. It was the social distancing and masking and paying attention to the infection control that really made the biggest difference. Now, it had a huge impact in terms of the economy, loss of jobs, all the things that we have. But going forward, we're going to have to maintain some of these infection control measures. Certainly, we need to do testing. Certainly, we need to disrupt transmission and continue to survey. So with that, that's the end of the talk. I'm open to taking questions. I can't really see. Do you have the screen for the chat? We have, oh, there's a lot of stuff here. Okay. Yeah, where do you have access to the slides? So the slides, slide access you can have through calling Baptist South Lexington. Margaret Kramer, you can get in touch with Margaret Kramer. I don't have her phone number off the top of my head. But the slide set is for all the talks previous to this, with some of them, you know, this is probably the most updated, but there's other slides that were just dropped that you can do that.
It's also going to be on.
And it's also on our website, lexidc.com, where the slides will be there, plus the talk will be there as well. Okay, so here's Rashonda, are you on the line? From infection control? Are you there? So Mark, why don't you answer this question? Here's an infection control question. After a person tests negative ×2, what precautions should be taken considering shedding?
That can be kind of a difficult question. I mean, most of the time we use that as a gold standard. If someone has 2 negative, adequately obtained PCR tests. Can you? Oh, so Rashawn is going to be on, but her mic is muted. At any rate, if you have 2 negative PCR tests were adequately obtained, in other words, they were a nasopharyngeal specimen, I think in the vast majority of situations, patients can be taken off precautions. If there is a clinical suspicion there was an inadequate test, or if there's some reason that you think the patient is a very high risk, on occasion we've obtained a 3rd specimen. We've had some conflicts in some of the tests. Some situations we've had 3 tests and 2 of them have been negative, 1's been positive. If you have a chance to do an ET suction specimen or a BAL, that's going to be better for the ventilated patients, but there are only some labs that will actually accept that. So Quest will accept that and LabCorp, but most of the other labs weren't, and they haven't been validated in a lot of the labs.
Rashonda, do you have a comment on, Rashonda is speaking through the iPhone, about 2 negative tests, what precautions should be considered regarding shedding? Are you there?
I'm still here.
Okay, you want to answer that question?
We're still keeping the patients in precaution until we get a definitive note from the physician to say that we can take the patient out. So we still have concerns about that.
Now, one of the difficulties, obviously, is getting those patients out of the hospital to a high-risk setting. Most facilities are not going to allow you to transfer to a nursing home with a positive PCR test. That's where we have a lot of barriers to transfer, whether it's sometimes to rehab and certainly to nursing homes. But remember that the test is a signal of the RNA. It's not necessarily a signal that the patient is still infectious. That has been the difficulty of using PCR testing. And I think as time goes on, we'll have better clarity about that as people publish more literature talking about, say you are still PCR. Remember, some patients can be PCR positive for 3 weeks, 4 weeks, but we don't have the follow-up that they were actually excreting live virus. That data are not there.
And of course, if you could culture the virus safely, then we could tell. If it was like herpes simplex virus, we could just culture and say, okay, well, it's no longer there, but it's not safe to culture this virus. You have to have a biohazard 3-level lab to culture it, so that's not really an option in this situation.
Do we know the mutation capacity of the virus as far as drift and shift? Could this be the new flu as far as yearly vaccination? So the answer is we know that there is some mutation. There are different strains that are being out there and articles written about mutation. The issue would be in terms of vaccination, it may end up being like the flu, where we have a difficult time keeping up with the antigenic changes of the flu virus. Because remember, the flu virus, which is also an RNA virus, likes to take parts from different animals and change its configuration so the vaccine does not work as well. That may happen. Right now, we don't have that information. We know that some of if they develop a vaccine based on the spike protein, that the spike protein tends to be more conserved, at least right now, even with the mutations. So potentially, if they had a vaccine based on spike protein, it might still be valuable for a while. But that's all new. That's got to wait. Any other questions from the primary care audience? Holly, you want to say a few words?
Yeah.
Let's let Holly Hall, Dr. Holly Hall, come, who's one of the hospitalists that has been working hard on the hospital care of the patient and also the discharge component.
Hello. So just maybe an update. We've been working pretty hard on trying to do what we call a warm handoff to our PCPs with our COVID positive discharges, making sure that we have a very protocolized education at time of discharge for the patient and their family members about how to do social distancing at the home when they go home until the patient's fully convalesced, more than just giving them verbal, quick tidbits, but really giving them some examples of what they would actually do about, how do you share a bathroom? How do you prepare food? And then the other thing was making sure that the attending who discharges a COVID positive patient calls and has a verbal conversation with the primary care attending that is the patient's follow-up plan, and verifying that there is the accessibility, because a lot of people, especially in the BHMG system, we're doing telehealth at outpatient, but not everyone is. Maybe some of our patients are from rural areas where their PCPs have not moved on to that access. So we just need to know what patients have access to, what kind of follow-up they're going to have. And then I know here, but I'm unsure of how it's working in other places, we're using through Current Health, we're sending patients home with a monitor that basically is going to monitor their pulse ox and give some real-time data feedback so that we can be sure that they completely convalesce at time of discharge. And this is being organized through home health. So there's a nice multidisciplinary approach to discharge with the hospitalist, the monitoring piece, the home health nurse, and the primary care physician, so that the loop gets closed and patients go home with a full plan instead of a loose plan and then leaving it in the PCP's lap to answer a lot of complicated questions that probably could have already had education done at time of discharge. We're trying to do that. So if any PCPs that are out there are getting our discharge positive patients and you have positive or negative feedback about what we're doing, or maybe things that we can't know what you guys are learning on your side. So what are the concerns that happen afterwards that you're having to deal with that we maybe could help you with before patients leave the hospital? Those are things that we would like to know about if they're helpful for you. That's just our newest piece that we were trying to make sure we had a protocol for. But if anyone out there has other questions about how we're dealing with inpatients, how we're dealing with those patients that need to go to rehab or, any questions you have, I can try to answer for you and tell you what we've found that's working best. Not necessarily that what we have is what we want. We're struggling with getting patients to rehab and so forth as well.
Okay, thank you very much, everyone. I think we'll probably go ahead and tie it up now. We're going to try to do this again in 2 weeks. I think seems like there's always some new issue to talk about, especially the surgery ramp up and the outpatient services ramp up and radiology, endoscopy, and so forth. So I'm really proud of how everyone's performed here, how our systems performed, and we all pulled together, and I think we've done very well so far in the state. Thank you. We'll see you later. We'll see you in 2 weeks.